Welcome, everybody. Good evening. How's dinner? Some thumbs up. Excellent. So nice to have you all and lots of new faces with us this evening. So thank you all for being here. We are so excited to continue our speaker series this evening as we continue to highlight a lot of the amazing work done by some of our local providers, especially in tackling some of our greatest health disparities in the area. I am thrilled to introduce Dr. Evan Ashkin, who is one of our beloved UNC Family Medicine faculty. He told me to take it easy on the bio, so I will, but please, everyone has the papers in front of them. Please take a look at that. But Dr. Ashkin is definitely one of the favorites at UNC Family Medicine. Has been an amazing preceptor. I've learned so much from him over the years, especially during my training and afterwards, and we're so grateful to have him here. We've got a UNC Family Medicine fan club over here in support of his incredible work. We are grateful that you took the time this evening to come speak with us about your work as the founder of the North Carolina Formerly Incarcerated Transition program. So thank you. And here with him, Tommy Green, thank you so much for coming and speaking as well about your experience. The work you've done is truly remarkable as well. I was excited to read your bio since we haven't had much time to talk, and I hope you continue to gain so much deserved recognition for the work you're doing in post-incarceration transition. So thank you both. I believe we become better advocates by learning more about our communities and our most vulnerable populations. And I know we're both in for a treat tonight and going to learn a ton. So thank you both.
Okay. Good evening. Hello. So thank you so much for inviting Tommy and I to come talk this evening. I would like to start off with a show of hands. During your medical training, I'd love to see how many people had content about the criminal legal system. All right, well, this is better than most. It's still not everybody, which by the end of this talk, well, if you're here, you're obviously interested in this, but we're going to try to point out how sort of problematic this is. We're going to try to make the argument that it's probably don't want to rank social determinants of health, like which are the worst ones, okay, because they're all really important. But I hope a takeaway from tonight will be how relevant being impacted by the criminal legal system is to the well-being of people, their families, our communities, and really we believe our entire society. So Tommy and I, which button do I hit to go? There we go. Okay, we're going to talk about some health disparities, painting a little bit of a different picture, and then we're going to sort of talk about how we got here today. And that really has to start in 1619. And then, which everyone in this room, and we're just talking with Paige in the ER at Duke Regional about the failure to address mental illness and substance use disorder and what has become the safety net in our society for folks who suffer from that, and then the resultant health disparities that we face. I want to briefly discuss a patient who sadly is probably very emblematic and typical of the kind of patients that Tommy and I now work with. But this is a patient who finally got me paying attention to histories of incarceration. So this young man, who I'll call AJ, was 28 years old, and he was brought in. I was working at the Prospect Hill Community Health Center, which is in southern Caswell County, federally qualified health center. He was brought in by his aunt and said, you know, he just doesn't look well. And AJ's story was he'd been released 2 years prior to this from prison system in North Carolina and had had no medical care since that time. And very quickly in talking to him, sadly I realized that his health literacy was about 0. He had significant intellectual and developmental disabilities, and had a history of diabetes, hypertension, chronic kidney disease, and being the family doc I am, I said, hey, let's take off your shoes and socks and take a look. And there were a bunch of gangrenous toes, and like that day he goes down to the ED at UNC, and that's the beginning of ridiculous complications that were probably mostly preventable, requiring amputations, temporary dialysis from some complications of anesthesia, temporary feeding tube from his gastroparesis. And the story does not end well. It just went from bad to worse. And AJ was actually then shot to death about a year and a half later, around Christmas time, after I'd met him. And with my good liberal outrage, I was like, oh my gosh, how does this happen that somebody with all these chronic medical problems is not connected to medical care? I mean, that makes no sense, right? Economically, I mean, you don't have to care about the person, but it makes no sense. But that is when I teach at the medical school and try to talk about systemic racism, that is how we wind up with these conditions, because it does make no sense. How is this young man discharged from incarceration without being connected to care? Because what happened to him is actually happens every day to thousands of people across the US. And that was the genesis of trying to figure out we could probably do better in North Carolina for people coming out of our prison system. So I just want to back up now to talk about, this is sort of a list of things that we know are social determinants of health, right? Which we learned about. Am I talking loud enough? Yeah. Okay. Okay. Is that better? Actually, me. So, how about that? Okay. So, we all know these things. But what Tommy and I are going to talk about is really how being in the criminal legal system exacerbates, perpetuates, creates so many of these social determinants of health that almost all of us have dealt with in our careers in trying to improve the wellness of the patients that we care for. I want to talk about a concept that I never learned in medical school or residency called allostatic load. And this is, I believe, important to understand when we're trying to wrap our head around, like, if race is a social construct and not genetic, why are Black men in the South especially too, right, dying of heart disease and stroke and prostate cancer and everything else at these higher rates? Like, what is the explanation? And I think allostatic load helps me understand this in a way that I really hadn't before, which is like, what is the impact of living life as a Black male in our society? What is the impact of growing up in a community that is over-policed, under-resourced, many people been incarcerated, higher rates of, sadly, drug use, poverty, poorly performing schools? What does that do to you? And then the racism which you will encounter daily in your life. And there is actually a genetic component to this, which is what we're learning now with epigenetics. So what does that do, that toxic stress, to the way you gene switch on and off? And actually, sadly, for women, this can now, we know, be passed on generationally through epigenetics in the ovum. So it's not, in males, we sort of don't think it is with sperm, but we definitely know it can be for females. So this has helped me understand this concept, but there's still a lot more we need to learn. All right, so how do we get to where we are today in our state of mass incarceration? So as we all know, it's slavery that began in this country 1619. And happily, we tried to abolish slavery in the 1800s. We failed on many levels, and part of their failure was the 13th Amendment loophole, where it was still acceptable to enslave people who were being convicted of crime. And that's what it says in the 13th Amendment, that slavery is prohibited except for incarceration. And I think, as most of us know, post Civil War, there was a period of Reconstruction, and that was there were fairly positive movements in the US, but there was a lot of pushback to post-Reconstruction. And we wound up with these Jim Crow laws, black codes, which allowed law enforcement to arrest people sort of for being black and being unemployed or being vagrant. And then we had, sadly, this convict leasing system, where then people could be leased out back to plantations or mining operations and other agricultural and industrial employers. However, you no longer were the property of those plantations. So in some ways, conditions, well, they probably were worse, because if somebody became unhealthy or died, you could actually lease another convict. Not much changed in our criminal legal system from those Black Crow black codes up until, as far as numbers of people incarcerated, up until what we now call the new Jim Crow and mass incarceration. And I think it's really important just to paint a little bit picture of what happened in the US. So in the world right now, pretty much 1 in 4, it's a little better, maybe 1 in 4.5 people that are incarcerated are in the US. And yet we represent less than 5% of the world's population. There are millions of people cycling through our jails, over 2 million people incarcerated in our jails and prisons, 6 to 8 million people on parole and probation. This is a 400% increase since the 80s, and for women, actually, it's an 800% increase. And how did that happen? Well, this slide, I think, is really instructive. What happened in the 1970s? Did crime go up so dramatically that we had to incarcerate 400, 800% more of our population? No. This was social policy that drove mass incarceration in the US. And it really was state policy, because if you look here, state prisons where the largest growth is, and local jails, and not in the federal system. So we all know about the war on drugs, and we now know from really written documents from the Nixon administration, it's not sort of just theory, that the war on drugs was really a direct response to civil rights movement, Vietnam War protests, Black Power movement in the US. And it was a way really to try and control those communities more effectively. And the war on drugs was prosecuted by offering law enforcement financial resources and actually surplus military equipment if they arrested people specifically for drug crime. And it's important, if you look back at the historical record, law enforcement was not complaining about drug crime during the 1970s. It was on the list, but it was on the list among many other things. But that is specifically what law enforcement was reimbursed for, was drug arrests in particular. Now, if you're in Durham, North Carolina, and you're the sheriff or you run the police department, you want to arrest people for drug crime, where do you do that? You go to Duke University, where you know that the rates of drug use and selling drugs is extremely high. Do you go to UNC Chapel Hill if you're in Orange County? Absolutely not. The drug war was prosecuted in poor communities of color throughout the US. And then sadly, media, movies, news really racialized drug use in the US to sort of solidify this idea that it really was communities of color that were the problem and that should be over-policed. But that wasn't the whole story. I'm going to get to the psychiatric story in just a minute. And it's important when I give this talk to try to show that there was not more drug use, because some people struggle with this idea, because I grew up, I was born in 1960. This is what I was inundated with growing up, is this is really, it's blacks in Harlem that are selling crack, and that's the problem in New York State with drugs. But the reality is, and you'll see this starts in 2000, we actually didn't even collect this data well, But the worst case scenario here is a 2% difference in drug use among like blacks versus whites. You can see here from 2000 to 2012. And today, from our National Survey of Drug Use Health, there's more use, lifetime use in whites than blacks, and about the same in the last 12 months. So I said there's that 2% difference, but there's a 5 times greater disparity in incarceration for drug offenses for blacks than whites. So you can't justify that by saying, well, you know, we had to incarcerate more black people because they were selling or using drugs more frequently. And then you all may know this issue of the sentencing, where in many communities it was 100 times greater. So the same amount of powder cocaine, you had to have 100 times more powder cocaine than crack cocaine to get the same sentence. And then there were mandatory sentencing guidelines, which perpetuated the mass incarceration and long prison sentences for people arrested for drugs. So what are we left with today? We're left with the fact that a male born in 2001, a black male, 1 in 5 chance they will be incarcerated during their lifetime. If you're a black male in the US and you don't finish high school, there is a 70% chance by the age of 40 you'll be incarcerated, 70%. And black youth are 7 times more likely to be tried as adults. That is very important, because when you're tried as an adult, your record is not expunged or it's not sealed. It follows you for the rest of your life. And you have that ball and chain of a felony conviction around you for good. So today, 1 in every 10 black men is 30s is in prison or jail, and youth detention is 2/3 people of color. Now let's talk about something that the failure of the mental health system. And this is you guys asked me to talk. This is depressing, okay? But you invited Tommy and I to come, okay? What happened? I'm old enough, a number of folks in this room probably remember deinstitutionalization of mental illness, right? That was a good thing. We developed antipsychotics. Yay. You know, the pharmaceutical industry has done some good things. Thorazine, right? You no longer have to spend your life in, you know, one flew over the cuckoo's nest if you had a psychiatric disorder. And President Kennedy signed this lovely law in 1963 that was going to create a community mental health system in the US to provide care for folks as they release. Well, we all know in this room that did not happen. So people were deinstitutionalized. The social safety net was thin at best, non-existent in most places. And now, if you see here, we have reinstitutionalized people with mental illness into our prisons and jails. And the carceral system is by far the #1 provider of mental health care in the United States of America, hands down. And we have a 95% reduction in inpatient psych beds in the US since the 1950s. And we are furiously building psychiatric units in our prisons and jails right now as we speak, because that's where people wind up with mental illness. So now if you have mental illness, you're 3 times more likely to be in jail or prison than a mental health facility. 40% of people with severe mental illness will be incarcerated. And as I mentioned, the decrease in inpatient psych beds outside of carceral system is dramatic. If you look at the numbers of people incarcerated, half the people in our jails and prisons are there for 2 crimes: being mentally ill or having substance use disorder. And is jail or prison a good place for treatment of mental illness or substance use disorder? No. We all know that either is the emergency room. That's become sort of a stopping point on the way to the jail for a lot of folks. But that's the reality. And when you look at this chart here, you will see public disorder, drug, and property crime for jail and prison causes. Almost all that is related to low-level drug crime, public disorder, being off your psych meds, right? Creating a fuss out on Franklin Street if you're in Chapel Hill, or 9th Street in Durham, and the police get called, and then you wind up getting hauled in. Right. To save time, I'm going to skip through a few things here. I do want to point out one thing, that it's very easy to leave out people with a history of a quote-unquote violent crime from criminal justice reform. And that's, a lot of people get that label. And I just want to point out here that if you have a history of quote unquote a violent crime, you can see here, you are the least likely actually post-release to have any problems. So leaving people out is also very, very problematic, but it's very easy politically to do that. So where are we at today? So 32,000 people are incarcerated in our state prison system, mostly male. This is the way it is across the US, about 10 to 1. We have about 76,000 people on parole and probation for over 100,000 people at this moment who are in our system, and about 20,000 people are released from our prison system. So think about that churn, 20,000 of the 31,000. So we have a lot invested in doing the right thing for people coming out, because almost everyone comes out so they can be successful in their lives, and yet sadly we fail to do that. I want to point out the racial demographics. As probably most of us know, we're 22% Black, we're 70% white, but our prison population is 50% Black. And if you can believe it, we do better than many states. North Carolina's rate, I gave this talk to a group in Pennsylvania recently, so I looked up their rate. Yeah, they have 50% Black in their prisons, but their population is only 13% Black. So their disparity in Pennsylvania is even worse. And then in our jails, which we have in every county, the numbers are also terrible. Most people are pre-trial, they haven't even been convicted of something, but the same racial inequities. All right, now I'm going to turn it over to Tommy to talk about how people get swept into the system, and for him to sort of talk more about who he is and the work he does.
So looking at the flow chart and trying to follow along with me, upon arrest, one of the first things you do is you appear in front of, oh, that is not good. Sorry. So can everybody hear me? Thank you. Okay, so upon your arrest, the first thing you do is go to the local jail and you go in front of the magistrate. Now, the magistrate is a person that decides on what type of monetary bond you get, and they use factors ranging from, they use anything from previous incarceration, previous charges, the severity of the crime. Sometimes they'll even take the time to speak to the arresting officer and get a little bit of details of the crime before they decide on the monetary value of your bond. And the bond is the monetary amount that you have to pay to get released from jail. So one of the first tricks of incarceration or getting people to be stuck in jail is that, again, the magistrate has a lot of leeway on the range that your monetary bond is, on the range of your bond. Excuse me, I'm a little bit nervous up here. I'm gonna go ahead and give that little caveat. And it's funny, we do this talk in front of a lot of people. I don't know what it is about you guys. Okay, so let me start over, try again. So one of the things, right, the magistrate gets to decide the amount of bond. And one of the problems with that is a lot of times the people that are getting arrested are working to lower class. So that's one of the things that gets them stuck. They don't have money to get released. And once your bond is set, you know, so your bond can range anywhere from 10,000 to $1 million, right? Depending on the severity of the crime. And one of the ways that you can get out of jail is that you get a bondsman, bail bondsman. And what they do is they come and they actually pay the bond and get you to kind of sign off and say that you'll come to court whenever your court date comes. But the thing about it is a bondsman only charges about 15% of the bond. So doing quick math, you know, if it's 10,000, then that's $1,500 that you have to pay to the bondsman. A lot of times, of course, the people that are getting arrested can't even afford that. So that's what gets them stuck in jail. Okay, now while you're in jail, another plea that the district attorney, who was the prosecutor in your case, they come to you with what they call a plea arraignment. Now, a plea arraignment is an agreement between you and the district attorney to accept lower charges. All right. And so a lot of times, working class person, using myself for an example, young Black man, well, at least I was young at one time, but young Black man facing charges, I'm working, I need to get out as fast as I can to get back to my family, get back to my job. So when the district attorney comes to me and says, hey, it doesn't really matter if you're innocent or guilty, but if you want to get out, I'll go ahead and offer you a lesser charge. And with a lesser charge comes lesser punishment. A lot of times the lesser punishment is like probation. So that means you can just sign yourself out and leave. A lot of times a person, again, in my situation, I would take that, you know. But what we fail to realize is something that, we talk to our clients about a lot, which is called collateral consequences of incarceration, which means the things that the boundaries and the rules held against you post incarceration. For example, a convicted felon can't get certain licenses. A convicted felon can't live in certain places, can't work certain jobs. So with that being said, back to me being the guy sitting in jail. Yes, I signed off on a lower class felony. I got to go home and only got probation as opposed to doing time. But now for life, I'm a convicted felon. So that's the catch-22 in it. And another thing, in North Carolina, we're under what you call the Structured Sentencing Act, which means that once you're convicted of a crime, the courts use the district attorney and the courts can use a sentencing guide based off a point system to sentence you. The more points you have, the higher your sentencing could be. Now, what causes you to get points? The most points you're going to get is your previous record. So now put myself back in that situation. I get out, got probation. I'm a convicted felon. Let's say something happens, I recidivize, right? So now next time around, I'm going to get more time because I'm higher on the sentencing guide. And again, everything that's attached with being a convicted felon. So that's one of the things that keeps the revolving door going. Like a lot of people don't understand that once you sign that first plea, you're really signing away your rights. You might as well look at it like that, especially if it's a plea for a lower class felon. That's the trick. Everybody thinks, oh, well, it's not that severe, but that guy that he showed you earlier with all those ranges of crimes on it, in every spot, you can have a felon, whether it's something as severe as robbery or something as minor as embezzlement, taking some money or something like that. So again, whether you are a class A felon or a class D felon, you still have these collateral consequences. And then just to give you a little bit of relevance of the differences between the actual facilities you'll be in, you have some juvenile facilities. I think we have maybe 2 in North Carolina, Pope and Foothills, I think. And then you have state prisons, which if you have state charges, that's where you would go if you had to do state time. And then federal prisons, of course, federal charges, federal crimes, federal facilities. And that's a really quick cap of how that works. And just to give you a little bit about myself before he really gets into the FIT program, one of the most unique things about the Formerly Incarcerated Transition program is that all the community health workers in the program, which I'm actually one of the lead community health workers, trying to share my board, are formerly incarcerated, which means we have a history of incarceration. And I think that's one of the most unique things about the FIT program in regards that we really believe in peer-to-peer counseling. And we really believe that, getting through to marginalized populations like the people that we serve, the best way to get through to them is to have someone that's been there, done that, to work with them. I'm sure Dr. Ashkin will get a little bit more into, how that started. But just again, to give you a little bit of background, all the community health workers formerly incarcerated, and my actual role, again, I'm the lead community health worker for the NC FIT program, and I'm also the program manager for the Orange County program, in which I actually work really closely with Dr. Ashkin. That's why I can kind of pick on him every now and then, and he won't get mad. But he's our primary care provider in Orange County, so that's how me and him kind of work together. So I've been his wingman for 5-6 years now, and I'll pass it back.
What percent of people take a plea?
95% of people take pleas, yes.
And what do you think a young Black male sitting in the Durham jail thinks are his chances if he doesn't take the plea is going to get a jury of his peers?
Definitely slim to none. And that's why a lot of people take pleas that are even innocent, might have been in the area or been with the people that committed the crime. And North Carolina is very good at charging people that are just there. I can give you a really quick story about my brother-in-law. This is a young man, never been in any trouble, comes from a great family, never really been out in the streets like that, but he did what a lot of us young Black men do, gravitate to the guys that's in the street. So he's hanging out with some guys, and these guys talked him into going and ringing the doorbell while they was going around back breaking in. And they really literally tricked him. It wasn't, hey, we're finna break into this house and ring the doorbell. It was, hey, such and such is in there. They waiting on us. Go to the door. And so he rang the doorbell. His people went around back, broke in. Everybody got caught. Okay, now he was in the situation that I just told you. Young black man young black man sitting in jail, high bond, family can't pay it, and then they come to him with a plea saying, "Hey, I'm gonna give you a lesser felony. You get unsupervised probation." And in North Carolina, what that means is you basically your own papers. Your probation officer checks in with you every now and then, but you're still kind of free. So people really jump on that opportunity to be on unsupervised probation. He got that. Okay, so now, like I was telling you before, now he's a convicted felon for life because of just ringing the doorbell, right? The last job that I remember him having was at Cookout. That's the only thing he can get right now. Can't find nowhere to rent. He's staying at home with his mom right now. 26-year-old man that's struggling like that off of a mistake that he made when he was 18, a few months after his 18th birthday when this crime happened. So that gives you a little bit of relevance to the type of people that are getting caught up in not only in the system, but getting tricked and taking these pleas, thinking they're getting the easy way out, not knowing down the line it's going to catch up with you. Yes, yes, ma'am.
That can't get a job, can't go work in a mine, a Walmart, or any of these big corporations to do a background check. Even if you were charged with a felony and were not convicted of anything by misdemeanor, it's still a full background check, a still full felony. And you want that it keeps you.
Thank you for sharing that. You just jogged an old memory of mine. I have never even shared this in our talks before, but I've actually been a victim of that. Before I actually had any convictions, I had got caught up in I was actually around a robbery and got caught up in the whole mess or whatever. But anyways, long story short, I got out of it. They dropped the charges. They figured out that I really wasn't with the guys that were doing the robbery, so on and so forth. Charges dropped. I had got a job at not Volkswagen. It was at a car dealership in Durham. Got the job. They told me they was gonna do a background check. They liked me so much they went ahead and gave me the job before the background check came back. I worked this job for a week. My background check came back. All those felons was on my record, and I was never convicted. My manager looked at that record and he let me go. And I even explained the situation like, hey, it was a mistake. I had nothing to do with it. As you can see, the charges dropped, and the paper says charges dismissed. But his response to that was, we don't even want no one with that type of record in those type of situations working for our establishment. So I've actually been a victim of that without no charges. Barriers to successful reentry. So a lot of things we see since we've been doing this work, returning to poor marginalized communities with little opportunity. Like I mentioned before, this population of people that get involved in the carceral system are usually middle class to lower class citizens. So their roots are in impoverished communities, and this is what they have to go back to. Criminal record, background checks, employment, 4,000 laws. That 40,000 laws of discrimination. That's those are the collateral consequences that I mentioned. It's over 40,000 of them. Lack of public benefits, including housing, SNAP benefits, which is food stamps. And that's, if you look at that one, go back to the top. Now, remember we said return to poor, marginalized communities with little opportunity. A lot of people do this, right? But another catch-22 in the system is that people that have a certain class drug charge, they can't qualify for SNAP benefits and some other benefits, some other social services, excuse me, like they can't stay in Section 8 housing. So let's go back to the top. If your only family is in Section 8 housing, that means you cannot even go to them because nobody's going to risk losing their home just to welcome home someone from incarceration. So that's a major catch-22 that we actually see a lot. Voting restrictions. North Carolina is a little bit better than some states. It's a few states that convicted felons can't vote, period. Right now, I think, and for a while in North Carolina, you couldn't vote if you were on probation. I think they recently changed that like the last year or two. And poor access to healthcare and substance use treatment disorder. Again, that's one of the things that the FIT program tries to address. And again, like Dr. Ashkin was mentioning, that now prisons are the biggest home for mental health patients, right? So a lot of times, instead of people getting the substance use disorder treatment that they need or deserve, they're incarcerated and sent to fend for themselves or figure it out inside. Transportation, major barrier. Nobody comes home with a license. Nobody comes home with a car. Luckily and fortunately, here in Orange County, in Orange County where we're from, luckily the FIT program in Orange County is managed by the health department. So I'm technically a health department worker, right? And fortunately, they afford me the luxury of having a county car to help provide transportation needs for our clients. But of course, we got caseload so big, I can't help everybody, but we do get them to as many places as we can. Things including rides to their appointments, social services. They face food insecurity, so we'll get them to the food bank. Go to court with them. A big part of community health workers' job is advocacy. Being the voice for the voiceless, being able to stand up in spaces and vouch for our clients, because a lot of times without a strong support like the FIT program, these clients are not going to get certain services, or they might be treated a certain way, trying to seek services on their own. And I think I'm a pass the mic now.
All right, we've talked about a number of these other issues, but it's just really, I think, to understand the argument we're making about not being able to address health disparities by having such high levels of incarceration in communities of color, we keep those communities poor. So when large numbers of people are incarcerated, and it's very expensive to be incarcerated for your family members trying to support you, and you're not making a living, you're not contributing, right? And then when you get out, you can't get a decent job with benefits. So it's part of the thing that keeps communities poor, because our tax base drives so much of our education systems, right? There's been a big difference between Durham and Orange for years because of tax base. What are the roads like? Is a business going to come and invest in a underserved community with poor infrastructure with higher rates of crime and policing? No. So it perpetuates this system, perpetuating these social determinants of health, and really driven by our criminal legal system's impact. And the impact on families and children is also devastating. The shame, the stigma. Many of you know about ACE scores. If you have an incarcerated parent, your ACE score is probably 5 times higher than a child without an incarcerated parent. Okay, let's go on to something a little more positive. Okay, so we've talked about these no linkages to care. And the good news is there's actually something really successful that can be done. So we modeled our FIT program in North Carolina after something called the Transitions Clinic Network. And this was very rare for academicians. Some very smart, fabulous women at UCSF in like 2005 went and talked to people impacted at San Quentin. Can you imagine they actually talked to the people first? They wanted to help. And they said, what would meaningfully assist in getting into services post-release? And the answer was people like us. So they started this model of hiring people that were formerly incarcerated, training them as community health workers, and then embedding them in primary care medical homes, which have been almost exclusively federally qualified health centers because of their mission, their dedication, wraparound services. And I'm happy to shout out Howard Eisenson here, who was the director, the medical director at Lincoln when I first started this program, went to Howard, pitched this, and he was like, yes, this is something that we need to do. This is part of our mission. So Tommy is that guy in the middle. Not an easy job. So he has to be an expert in all things reentry. People we work with need comprehensive assistance, and we don't silo it. So they need Tommy to help them get their birth certificate from Ohio so they can get their driver's license. He's going to do that. If their main concern is family reunification, he's going to maybe supervise a visit with the parent and the kid so that they can maybe get their family back together. He's going to take them to the food bank, help them with housing. This isn't referrals. This is like hands-on, high-touch peer navigation. Then referrals. So if you could ask anybody in this region who's involved in reentry, they know Tommy Green. So, Tommy is well known in the community, And so we get a lot of referrals from all other kinds of reentry organizations doing this work. And then super importantly, and this is what's different about FIT, is Tommy is on the clinical team at Piedmont Health Services. And our community health worker in Durham is on the clinical team at Lincoln. And that has been what's lacking in reentry in the US. We have not been at the table. So we can guarantee people are going to get in. Again, Tommy knows everyone at the clinic. There is no problem for Tommy if he calls the front desk and says, so-and-so needs to get in now, they're out of their meds, they want to start Suboxone today, whatever, they're going to get in. And that is crucial at safety net clinics, which are also lots of struggles. I have to tell you all here. I don't have to tell Howard. But, you know, having that person really, really helps us. Almost everyone has been uninsured, and sadly with Medicaid expansion, it's changing, but not a lot. So we're now in 6 counties, soon to be 9. Everybody in the FIT program, we cover their sliding scale. So if they go to Lincoln, and we actually do better than that because we want to make it attractive. So Lincoln may have 20 or 25 bucks, we give them 100. And we're not an insurance company. So if they see behavioral health the same day, guess what? They get another 100 bucks. And if they send them to dental that same day, they can get another 100 bucks. It's still nothing, but it's something. And then we'll pay for meds. So we will pay for up to $100 per month, and we'll pay more. But we like to set a limit because this is grant writing and all that kind of stuff. So we try to keep a little bit of a lid on that. And then, you know, we work furiously to get people now on Medicaid ACA. So as I said, our program is now up and running in these counties. We actually have 20 community health worker positions like Tommy funded across the state doing different work. And we got very involved in treating people for opioid use disorder. Because as you all probably know, #1 cause of death in the US, period, under 55 years old is overdose. Not heart disease, not cancer, opioid overdose, #1 cause of death. We have a highly effective treatment and we are not doing it, right? Only 1 in 5 Americans with opioid use disorder is getting this treatment. And if you're in the criminal legal system, it's awful. Because when you get incarcerated, if you were on it, they take you off it. Because somehow they think they have a right to withhold that medication. They know they can't stop your insulin, but somehow they think they can stop those. But we went to the sheriff in Durham and Orange, and we started going and said, this is wrong. And both the sheriffs were like, okay, what do we do? So we actually helped get those programs going. So now if you're incarcerated in Durham or Orange, you stay on your MOUD, medication for opioid use disorder. Thanks. And initially you'll be offered initiation if you're not on it. And then we started working, the prison system happily realized they needed to get on board and actually asked us to help with that. So we worked with the Mountain Area Health Education Center folks, and there's now a program, it's still too small, but at the prison system, mostly for women coming out of women's, and Orange Correctional, where we're getting people started as well. Okay, so our thesis is that if we're going to address health disparities in the US, we have to address mass incarceration. And if we're going to talk about racial health disparities, it is problematic not to talk about mass incarceration because we are avoiding one of the main drivers of racial health disparities in the US. And when we don't talk about it, when we don't recognize it, we give it a pass. And we somehow focus on, which is right, food insecurity in schools and all these things, but what is driving those things in communities of color? If you know, all the Black men are locked up or have histories of felonies, if 70% of unfinished high school are going to be incarcerated. So we have to address this. And medicine needs to step up. We need to be a voice. And we also need to do a lot better for people that come into our care. Because all of us have seen people brought in orange jumpsuits, shackled with 2 armed guards. Now, if we don't teach this, if we don't talk about this, what should any intelligent person think when they see someone who shows up shackled with 2 people with weapons? What are you supposed to think? Dangerous person did a horrible thing. I mean, what else are you supposed to think, right? But you have to realize almost everybody is there because they are not a dangerous person and they did not do a horrible thing. Right? They have an addiction. They have mental illness, property crime, came from a community of poverty, made a choice that wound up with incarceration. But we don't do that. also what it does is it reinforces the stigma. It reinforces the bias. It reinforces the racist ideas going through our head. Because if it's a person of color, and Tommy, if we had more time, he'd tell a story going to UNC, that story, you know, where he was terrified because everyone treated him like he was Hannibal Lecter, because, you know, he's a big black guy shackled with armed guards and he cut his leg falling off a bunk. So we need to talk about this, and we need to not look at people's charges. It has nothing to do with our role as a healthcare provider, right? It is not for us to decide, did they take a plea? I mean, who knows? It's not our role. They have security officers there, right? That is their job. If this is actually a dangerous person that did a terrible thing, that's their job. But our job is to show the same kind of humanity that we try to show all of our patients. And remember, they're coming from a dehumanizing system where it goes such a long way if you are able to treat them in the way that we all want to treat them. If you're sitting in this room, I know that you want it to be different for those folks. Okay, we're going to move on to some questions. I just want to, if you have not read The New Jim Crow, at least watch the documentary 13th on Netflix. It's free, by Ava DuVernay. She interviews Michelle Alexander a lot, but I really would love you to read that. And then also there's an article in The Atlantic, Locking Up People There's No Way to Treat Mental Illness, which is very depressing, with a great review of what we've been talking about. And now Tommy and I would love to answer some questions. Howard.
It seems like one place for intervention that's important is to counsel folks who get arrested when this whole plea bargaining thing materializes. Are they being properly counseled about
Okay.
It seems to me that one potentially impactful place to intervene is to counsel people who are approached and offer a plea deal about the reality of what that might lead to them. Is that happening in the system?
Absolutely right. Well, so a plea deal is a negotiation between the district attorney and the public defender or personal attorney, if someone has the money to hire a personal attorney. So it depends on like which one you're kind of dealing with. So for example, not to knock any public defenders, but public defenders have a tendency of having a huge caseload, right? So they're not as motivated as like an attorney that's just being paid for their time to really sit down and talk with you about things like that. And more or less collateral consequences, the things that happen after that, is rarely talked about, period. Now they'll give you the ins and outs of, you know, your chances of sentencing if you don't take the plea, or or they'll advise you on, you know, how they'll advise you on whether or not you should take the plea that they're offering at the time. Because sometimes the district attorney will come to you with more than one plea. But that's the end of that conversation. Like they'll just tell you the specifics, the upfront things. But they never really sit down and say, well, you know, you can roll the dice and not take this plea and fight it possibly, but do realize that, you know, you can take the plea and face a lot of these things that, well, I mean, again, it's just not a conversation to have. Yes, ma'am.
I mean,
Can you just repeat that for the benefit of those who couldn't hear?
yeah, I just want to highlight that a lot of people, my clients, don't even get counsel. Now they have a right to counsel, but this idea that they even take that right is not. You're 17, the DA comes in and says, we're going to give these 5 charges, but if you take this plea, they're down to 2, and you're going to walk out of here, and you're like, yes, where do I sign? And they don't even get counsel. So it is a horrific system. And it depends what county you're in too, whether they're who the district attorney is and who the public defender is. Go ahead.
Is there any data to suggest that there is a reasonable likelihood
how often do people not take the plea bargain and actually benefit from having not taken?
I don't think I know that. We could probably ask our friends at the Wilson Center for Justice at Duke, and they might be able to answer. But it's our clients across the board, it did not go well, almost no matter what they did. They took the plea or not, it doesn't go well. Yes, sir.
As someone who's actually been a public defender,
Okay.
and actually dealt with this from the other perspective, sometimes the counseling conversation is, you take this plea and get out to get back to your job, or are you taking a deal where you're going to lose your job, you're going to lose your housing, and so even if there are collateral consequences that are in the conversation, there's the immediate necessary concerns that trump possible not being able to get a better job or long-term impacts, even when we're having that conversation.
I mean, thank you for bringing that up, because it's really, I mean, the system is so broken and the supports are so lacking that there is no good choice, right? I mean, it's not like, oh, you know, I have an obvious choice to ameliorate this. You know, you were at a party, things got out of control, a bunch of people got rounded up. There might have been a gun, there might have been some drugs, enough to say intent to sell, maybe property damage, maybe sex work, and all of a sudden you could be charged with 5 things you had nothing to do. And the context, just important to understand, so many people are in the system, especially if they're a person of color, because of that story. And that I just can't stress enough.
I just want to make a comment. I think that Dr. Ashkin's county physician, he saw a problem, heard about a problem in society. He said, well, I'm just a doctor, I'm just trying to treat my patients, and that's what I do. Because if we do that, if we advocate the responsibility of advocating the greater community, the community will suffer. Who will we make it to if we as physicians don't get involved? That will help us really the public issue. They really did. They know very little about health care. But yet, they are the ones who say, well, it's a societal problem. We'll leave it to, government. That will help us if we don't get involved. And we took on something that's very challenging. A lot of people along the way, I'm quite sure, we say, you can't do that. It won't work. There's all these barriers. But he's persistent. I think that should be an inspiration to all of us. It's a problem facing society. Get involved and try to form a solution. Whether it's abolishment the way healthcare is paid for in the United States, whether it's firearm injuries, gun violence. Some morons in Congress say, well, that's not a problem for doctors to worry about, gun violence. We should be worried about it. So, thank you very much.
Yes. A couple of answers to that question. Thank you for it. So, one thing is to make this less invisible. It is important to talk about this with your colleagues. And you're a psychiatrist, and we know that so many of your patients are at risk for incarceration if they haven't been. And we can also ask our patients, like we screen for other social determinants, but I have a recommendation for how to ask. First of all, if you're a white guy like me and you have a black guy like Tommy, the first visit, you probably don't freaking ask, okay? But after you've hopefully established some trust and rapport, now Paige is different for you because you've got that one visit, so, but the way you can say it too is, hey, I understand that people that have been in the criminal legal system face discrimination in so many aspects of their lives. They face, and I keep saying this, discrimination in housing, discrimination in employment, and I save healthcare for last, and I say, and discrimination in the healthcare system. So I'm highlighting me. And then I say, I wonder if you or your loved ones have experienced that. So I'm making it really clear I'm asking because I know that they've been shafted if that's the case. Because every time someone discloses that, they get discriminated against, right? So you have to ask in a way that really makes it clear. Now, then do you have a solution? No, but there's people like Tommy Green, who also not just runs the FIT program around here, but also Tommy has a business where he works with people, giving them life skills post-incarceration. You can learn like local reentry council. So part of your answer, Durham and Orange County both have awesome local reentry councils where people get together every month who are concerned about reentry. That's how I started learning. I just went to those meetings and I started meeting people doing reentry to understand what the needs were. So that you can just go and listen there, understand what the resources are in your community for people that have been impacted. And also though, just being a provider that has taken the time to understand, we all know how powerful our laying on of hands can be with patients. And that's very impactful. Yes. Education is one of the most effective interventions that can be done. If you give people an opportunity for education, but remember we took away Pell Grants, we almost destroyed the education system in prisons in the US, you reduce recidivism, I believe, by 5 times. It is one of the most powerful things. But I'm also going to brag about our program. If you're in the FIT program, we've published our group, Health Affairs, JAMA, BMJ. We reduce hospitalizations by half, ER utilization by half, days incarcerated by 45%. We've proven a return on investment. We've shown reduction in parole and probation violations. So if you do this work, you can have an impact. And by stopping, especially the recidivism, really important, because that is an upstream impact, right? I mean, we're pulling people out of the river, the babies out of the river public health analogy, but we're stopping them from getting thrown back in by helping them not get rearrested. There was, Dan.
Let's clarify one thing. So if we do send someone and they day somebody in the legal system, what are the options for how do we generate a referral? And the second one is different.
Go ahead.
The second question is, I understand Durham has a peer program for driver's license restoration and expungement. And I'm curious if, one, like, what we think about it is sufficient, is it lacking? And then two, have we seen any models of providers generating referrals to that program to help people become eligible for resources that they may not otherwise be eligible for?
I mean, the work that Tommy and I have done, people now know us, so we get referrals. And but an easy referral for any of you here is the local reentry council. Durham has a fabulous local reentry council that's part of the criminal justice resource. Anyway, CJRC, the Durham local reentry council Durham. If you Google that, that is a great resource, and they're also broad, not siloed, help with education, loans, expungement, driver's license. They're really a repository, same in Orange County. So that is a really effective referral. And then if you have a FIT program, like at Lincoln or in PHS, you can refer to Tommy at Piedmont Health Services, or you can refer to Roxanne Brown or our Bryant or our community health workers who are hired through the health department.
Just that their program he's talking about, expungement specifically, a lot of people will get excited about expungement. This is a great thing, but it's 22 to that as well. Expungement is you can only get one, and it can't be about the product. So it's a good thing, but it only helps a very small percentage of people at the time.
Yes.
Yes. Only applies to the state registry. It's still listed on the federal system. If somebody gets a background check, that is never expired.
Yes. Expungement is definitely state level only.
And you know, part of this thing following you, like the holy grail is for us to help people with a on the sex offender list, which, just to remind you, can be an unhoused person urinating behind a gas station getting arrested for indecent exposure, or someone who raped a 13-year-old daughter of their girlfriend. And they're both on the list and look the same and you have this, you are done. I mean, you're on that sex offender list, you are done. And also the ability, if someone is on that list again, to show them loving kindness and treat them as a human being is enormous, because they are vilified and stigmatized in every aspect of their life.
Male brains don't really mature. And a lot of these are young men who are getting caught up in things that they don't have the wherewithal because their brain is not fully developed to understand what the consequences. They get caught up in these things and then they can't get it off of their life. And even if it's just a misdemeanor, it really is a life sentence because it never comes off. It always affects.
Any other comments or Nima?
You had mentioned, I guess, incorporating this into medical education and trying to teach or reshape the future positions or current positions. What is your take on the swing of, I'm not sure what group to call them, who think that social medicine should not be involved in medical education, and that people are like advocating for it to be removed, and that it isn't important, or that equity or DI is, but that's.
I mean, it's chilling. And, Tommy and I have had, we've talked to most classes at UNC Med School, and occasionally we hear that a couple of students have been unhappy, but not much. But this is very insidious, and it also then allows. I think the other part is, if you didn't really want to do it in the first place, it's now a convenient excuse not to do it because you're not going to, get in trouble. Especially, I mean, Duke is different because it's private, and they happily have not had to step back from DEI statements and inclusion, equity. But I think it's super challenging at public institutions in states that have conservative legislation. And there's real risk. I mean, it's not, I don't want to downplay the risk and say, well, we just need to teach it anyway, because, which we do, but we have to temper it. And that makes me ill to even say that. But I think it's a very difficult time, and we need to be here to continue on. But I don't know how to do it yet. Thank you.
So I thank you for talking about the Reentry Council. I was unaware of that and was looking at some of us travel outside of Orange County and North County to receive patients, and was curious. It's only in 17 counties, and just curious if you can advocate to have it open in Chatham County, or it looks like in Alamance County there isn't one. Do you have any input for navigating that?
So something really exciting. Governor Cooper created Executive Order 303 it was in February, and basically instructed every state agency, no matter who they were, to focus on reentry. And the state was one of the first to join a federal movement called Reentry 2030. And with that, there's funding now for 27 more reentry councils, in addition to the ones we have across the state. And there will hopefully even be additional ones. So, it's not going to happen tomorrow, but this is the kind of thing that we can advocate for, because the reentry councils have been very effective. So this is something that we can all do in our communities. And this is a great use of opioid settlement dollars, which part of the other work we do is we do technical assistance around the state on this issue. And it's a great way to spend opioid settlement dollars because it directly addresses, obviously, so much of the harms created by it. I know we're at time.